Welcome to our panel. I'm author Kleinman, and I'll introduce the other panelists. Until July, I was the head of Harvard's Asia Center, and I've worked on China since 1960s. I'm both an anthropologist and a physician, and today's panel is on health, on aging, on cross-national comparisons. But actually, to frame it, let me say a few introductory remarks. So quite different from the remarks you probably heard yesterday, because I have a somewhat irreverent and in some way disappointed view of China studies. So China studies, like all area studies, are in big trouble today, big trouble. The historical, literary, and linguistic dimensions, cultural dimensions as well, of the study of societies around the world is in decline largely because of reduced funding and because the outcome for students in these fields has not been nearly as strong as it was in the past. So many of the things that you heard from Steve Orland's last night are simply not true of the present. Steve came online, as I did, at a very different time, as perhaps some of you in the audience have. So the first thing I want to scale up is that this panel responds to a tension between area studies and global studies. The new boy on the street is global studies, global environment, global health, global aging, global trade, global commerce. And what distinguishes global studies generally from area studies is that the people doing global studies tend to be less involved with a deep understanding of the local setting. And therefore, the opportunity occurs to amalgamate, as it were, or at least bring together in some way area studies and global studies to provide both the power of methods and generalizability and currency, which global studies brings, and the power of context, deep understanding of context, which local studies bring. And I hope on this panel you'll see some efforts in the way of trying to do that. Secondly, in this era, in the current era, there's been a diminution in attention to comparisons across nations and across societies. And that simply is a reflection of the fact that almost all of us have been trained in to be more and more specific about our topics in more local settings, meaning that we're comfortable talking about a particular place, but not necessarily making comparisons. In an earlier era of China studies and area studies generally, comparisons were routine. And so one of the things we're going to see on this panel is comparisons of China and India, which I think are often eye-opening. Third, health, aging, medicine, and science, which is really what this panel does, opens a special window on Chinese society, as it does on virtually all societies. And I think that you will be able to see some of the advantages of that special window that's opened up. And lastly, and this is a point that is also, I think, will be pretty clear in the panel. Social sciences in our time right now are in deep trouble. Social sciences dominate China studies and the studies of most societies. Social sciences are in deep trouble. And the trouble that they are in is an interesting one. If you go back to the founding of social sciences and read Adam Smith, John Stuart Mill, the great French early social scientists, systematic social inquiry was meant to do one particular thing. It was to understand societies in order to improve people's lives and to improve societies themselves. That whole concern with improvement went out the window as social science turned to the study of society for its own sake, much in the way that astrophysics studies the planets in terms of their own sake. In our time, social science has been called back to its originating interests with the question, what do you contribute that's useful to helping people and helping people's lives? And I think that China Studies over many years has done many useful things, if not least to provide a moderating and objective and thoughtful voice to counter the tendency in our society to China bash. But I think today in this panel you will see practical things that the study of China can do to improve U.S., not just to improve U.S.-China relations in keeping with what Steve said last night, but more generally to improve Chinese society and American society. And I think that I hope you'll pick up on that. So with no further ado, let me turn to the panelists. Our first panelist, and we're very fortunate to have her, is Winnie Yip. I've had the very good fortune of collaborating for years with Winnie. Winnie has replaced Bill Shao. Many of you remember Bill, who was an outstanding figure at Harvard School of Public Health on the healthcare system, not just of China, but virtually all Asian societies. Winnie is a major figure in the study of health systems reform, with an emphasis on China, but not only China. After Winnie, we will have, and Winnie has just come back from Oxford to a sign of the decline that the UK is in, to Harvard, and we're delighted to have her here. And then Prerna Singh, who was at Harvard in political science in our government department, and is now, unfortunately, in the political science department of one of our competitors in Providence. I'm not going to mention the name. But Prerna, whose first book was specifically on India, how solidarity works for social welfare, subnationalism and social development in India. Prerna has for some years now been working on China-India comparisons, using the history of medicine, the history of science, to understand different trajectories for responding to health interventions in the two societies and what can be learned by that. And then last will come me, and I'm a jack of all trades, master of none, and we'll talk about research that I have underway, particularly focused on elder care in China and in other Asian societies. So, without further ado, let me have Winnie start. Winnie, please.
Good morning. Can you hear me? So thank you for coming to this session on a Saturday morning in a bright day. So thank you very much for your kind words, Arthur. I'm going to do a presentation on China's healthcare reform, and relating to that are some of the research that we have conducted that try to influence the decisions and also the policies that have been made in China before, ongoing, and in the future. And as I deliver my talk, I will try to do the assignment that Arthur gave me. That is, how do I put a Chinese studies in a global context? What is the relevance between China and the global world, and that tension between looking at a global situation as opposed to also understanding the specific institution and contextual conditions of a country. How many of you here are familiar with China's healthcare reform? So I know how fast or slow to pace it. So let me just give a few background, because it seems that the majority of you are not that familiar. In year 2009, China introduced a major healthcare reform, and I call it a major healthcare reform with a big R. The scale and the potential impact, I would say, is unprecedented in recent history of China and also in the global context. And I'll tell you why it is the case. So when China introduced this reform, the goal that was declared was very, very clear. It is to assure affordable and equitable access to effective, basic health care for all by 2020. Now, this is a lot of things packed in one sentence. But for those of you who study global health, you will realize that this is actually the same goal that many countries around the world have declared, which is practically universal health coverage. It's identical. You go to India, you go to Africa, you go to many Asian countries, that's the goal, universal health coverage. What is different in China, as I have italicized that word, is the Chinese government only says that the goal is to assure affordable and equitable access to effective basic health care rather than all health care. And this is a reflection of a deep discussion and deliberation among the Chinese leader as to what should be the role of the government in terms of healthcare. Is the government responsible for everyone and every service in healthcare, or should it be just some of it? And the conclusion is that the Chinese government's view of healthcare is it is not a welfare. In other words, the government is not going to provide health as a welfare. The government has responsibilities to assure that everybody has access to basic health care, but it has never been willing to draw that line of what is basic. And this is a fundamental problem that the whole world is facing. And therefore, many countries are looking at how China is trying to define what is basic and how is defining what should be the role in financing, in delivering health care, and what should be the role of the market. The motivation of this healthcare reform for many of you who follow even just newspaper is very clear. It's just to reduce this problem of what we call unaffordable access to healthcare and also impoverishment due to paying for healthcare. And China is very good at slogans. So there's this 6-character term that everybody knows about it, which is 看病难,看病贵. You just say it, it encompasses the meaning of unaffordable access to healthcare. And you would wonder why, after complaint from the society for over 20 years about unaffordable access to health care, why is it is particularly in 2009 that this major healthcare reform was announced? And I would attribute it is because it is actually introduced during a regime of the government. Remember, under Hu, when the regime of the government was promoting what they call harmonious society. And if we unpack what harmonious society means, it really means equity. It really means balancing social development and economic development, rather than the previous regime, which gives much higher priority to economic development at the expense of social development. And it is under this broader government principles that this healthcare reform was introduced. And during the discussion, we can draw a little comparison with India's healthcare reform, because at that time I was also somewhat involved as well. And why did I say that it is significant in Chinese recent history and also by global standard? In order to carry out this reform, the government actually committed to double its spending on healthcare, and increasing its spending from 1% of GDP to 2% of GDP. But what is even more impressive is that they actually do spend it. Because around that time, India also entertained the idea of doubling its spending on healthcare from 1% also to 2%, but it was never realized. And in fact, by now, Chinese government spending on healthcare is up to 3.3% of GDP. So what is it being spent for? And I'm not going to go into much detail. 50% of this additional money is actually spent on establishing and expanding public health insurance programs to cover everybody. Now, again, this is a global trend. If you look around the world, most of the new government money is not going directly to facilities anymore because of this unclear and also uncomfortable idea that a lot of the money that is just given to public delivery services is just gone to waste. So it is a new movement around the world that additional money should be actually invested in insurance programs, and here I mean public insurance program, and let the insurance program be the purchaser of health care for the individuals, and they can purchase care from equally public or private provider. And the whole world is doing it, and I would say that the whole universal health coverage movement has somehow drowned the world, that everybody is now very busy trying to establish insurance without thinking that whether the way they establish their insurance is actually producing benefit for their people. And the world is also then struggling with answering this question. Even China is doubling its spending on healthcare, it still will not be able to cover everybody for everything. So what should they prioritize in terms of population and in terms of services? This is a debate that is going on in the world. Everywhere that you go, that's the question that people ask. And China took a very strong position, that is, the priority is to cover everybody first, which means that the scope of service to be covered initially would have to be shallow. And I remember during the early time of that reform, I go to every international conference, every international organization criticized China, thinking that China just want to cover everybody by doing it in a fake way, covering in a shallow way. But I think China is actually doing it right, and I think the world is slowly recognizing why. Because if you initially cover everybody, even though the coverage is shallow, but over time when the government invests more, everybody who has been covered get lifted up equally. Whereas in the rest of the world, what we have seen is when the government initially tried to cover civil servant first, tried to cover employee first, and the poor first, and when more money comes in, these initial groups capture the money. So you always leave a big group in the middle that has not being covered. So out of the principle of equity, then what China has done is now being considered a good models to be learned from. The second lesson that China has for other countries to learn from is that the central government plays a very strong role in redistribution. In setting up these insurance funds, the individual household only pay for 10% of the premium. The government actually subsidized 90% of the premium. But then when I say government, you should ask me, is it the central government or is it the local government? In the western poor provinces, the majority of that comes from the central government. In the middle region and the eastern region, the majority of that funding comes from the local government. It is the government's exercising its redistributive power to give more of its limited funding to the areas that are poorer, so that all regions will be able to afford this healthcare. And so this is the second lesson that the world is learning from China. But when China initially set up this insurance program, it also made a very, very big mistake, because the whole world feels that when people are driven into poverty by paying for healthcare, it's due to hospitalization. Outpatient services will not drive people into poverty. Now, I have to say this is a very Western view. And if you look at data from China and from lower and middle income countries, in fact, a majority of the households were driven into poverty because they were paying a lot for drugs. They were paying a lot for outpatient services, especially with the increase of chronic conditions, when people have to have repeated health care. But at that time, China actually followed what the world has done. And if you look at Ghana, Uganda, India, all the social health insurance program at this moment is covering inpatient services. And China did that. And what is the consequence of that? The consequence is that people actually don't use healthcare. People don't go to primary healthcare. People don't go to preventive services. They wait until they are acute enough, and then they try to convince the doctor, admit me to the hospitals, because once I get into the hospital, I can get reimbursed. And so what happened is that within a short period of 10 years, hospitalization rate in China has gone up from 3.6% to 16%. What does it mean? In every year, out of 100 persons, 16 persons would have been hospitalized. And what is the OECD average? 3. And as I said to my Chinese colleague, it looks like the more reform that you have, the more money that you pump in, you get people sicker. So China has done very well in certain areas, but it has also made mistakes. But it's all right, because the mistakes are also valuable lessons for the world. So it is against this background, let me just skip those. China raised this fundamental question, especially Ministry of Finance. How can we organize the healthcare system so that additional funding invested will actually be turned into effective services rather than wasteful use of services? And Chinese government's way of looking for a solution is actually encourage local government to do experiments and pilots. And this really carry all the way from Deng Xiaoping, because Deng Xiaoping's philosophy for reform is you cross the river by feeling the stones. That is, you don't know what is the solution, and the way to do it is you try it and you test it. And this actually opened quite a broad field for local academics and international academics to go into China and work with the government in a collaborative way to help them find solutions. So the work that I have been doing to a large extent is trying to understand what are the problems, what are the issues that the healthcare system China confront. Can we take a solution that other countries have already discovered and then adapt it to the local situation, given its institution, given its constraints and opportunities, to redesign it to something that would be feasible and effective, but I emphasize that is sustainable. In other words, it is not my research project I'm interested in. I only want to do this research because it can find a solution that when I leave, the government can actually take it on and make it a policy so that it have a continued effort. And against that background, we conducted quite a few social experiments, in particular in rural China, partly because I feel that as academic, if you want to turn your knowledge into effects, I want to focus on helping the vulnerable population first. And so let me illustrate one of the experiments that we did in Ningxia province that many of you know that is one of the poorest provinces in China in the northwest. We started a baseline analysis, and when we started, Ningxia already had established this public insurance that I talked about. And we did a survey of 35,000 households. 25% of the individuals said that when they were ill in the last 2 weeks, they did not seek care. And what is the main reason for that? 40% said that it's still due to financial reason. So we will be puzzled. There is insurance. Why is there financial reason that people don't seek care? 25% of the household suffers from what we call catastrophic expenditure, meaning that 25% of that household's income is actually used for paying for health care. And this is severe because international studies have taught us that if you spend that much of your income on health care, it means that other spending, in particular in rural areas, that would be sacrificed. The number one thing is actually education, and it's education for girls. So it has long-term consequences for a lot of social development purposes. A third of the villages don't even have a village doctor because the village doctor felt that actually going to the city to become a migrant worker earn more than staying in the village to be a village doctor. Primary healthcare providers, healthcare is absolutely low quality. Out of a huge sample of prescriptions for cold and flu, 50% of them were given antibiotics. You and I know that that is not necessary. 20% of them were given IV injections. Remember I said earlier that people are still spending a lot of money? But there's a fundamental question is, it's actually spending money on things that are not useful. So the question is, how do you reduce the spending on these unnecessary and wasteful things and use that saving to put it into intervention and services that are more effective, that can actually improve people's health care? Hospitals, even worse. Expenditure for at the hospital increased at 15% on an annual basis. Think about what insurance fund is able to sustain that kind of huge increase in expenditure. What kind of income will be able to sustain that? No wonder so many people are driven into poverty. No wonder so many people are driven into catastrophic spending. And the services are poor. And not just that, a lot of people, and many of you who live in and come from China will know that Chinese like to flock to tertiary hospitals, right? From the people from a rural area go to the provincial hospitals. The people who live in a provincial city, they actually go to Beijing. Right, the Beijing is the final destination. But if you look at the kind of condition, we analyze a large amount of data on what are the conditions that they go and seek care. Well, yes, some of them are like cancer that a county hospital is not capable of treating. But some of them are basic things, including appendicitis, including pneumonia. And that's actually very wasteful of resources if for things that a lower level facilities can deal with, you have to all flock up to the big hospitals. So these are the conditions that were identified. And so, of course, we're trying to analyze what are the underlying reasons. One underlying reason is the insurance, as I said earlier, only covers inpatient services. It doesn't cover outpatient care. It doesn't cover village doctor services. It doesn't cover township health center services. No wonder people don't actually go there to try to get their hypertension managed. No wonder people don't go there to get their blood glucose checked in order to check their diabetic condition. But I would highlight a very big problem in China, which is unique to China. 90% of the service provision in China is by what we call public providers, public hospitals, public clinics. But the behavior of public hospitals in China are exactly the same as for-profit providers in anywhere in the world. This is a problem that is unique to China, and many of you know the historical reason. So China's provision and delivery service now suffers from both a for-profit driven behavior, but at the same time subject to typical public service inefficiency. That is, they are subject to bureaucratic management and rules. You all know that hospital directors actually don't have the right to hire and fire a staff because all the staffs are actually assigned by the Department of Organization. The hospital director is not chosen by merits. They are again appointed by the government. So they don't feel accountable to the people and the patients. Their accountability is to the government. So what we did is then, with the understanding and collaboration of Ningxia government, we tested a reformed model of changing the way insurance is being designed and changing the way that providers are being managed and providers are being paid, using financial incentive to change the motivation and the practices of the providers. In other words, instead of paying the provider for every drug that they prescribe, paying the provider for every CT scan that they do, every X-ray that they do, providers were actually given a fixed budget that they would have to manage that budget. However, 30% of that budget will be subject to quality assessment. And it is lessons that we have learned from the world. And we try to use it for China, but again, adapt to the particular situation in China. I won't have time to go into the detail. And so what we do is we experimented it in 2 counties with a total population of 600,000 and follow them for 4 years and then evaluate the effects. And we were able to achieve the following outcome. We increased visits to primary health care by about 67%. We reduced the incidence of catastrophic expenditure by about 20%, but only 20%. Yes, it has an impact, but it's still a long way to go. We reduced antibiotic use for simple health conditions by about 33%. Again, from the government perspective, big effect. From my perspective, still a long way to go. And we were able to reduce hospitalization at big and large tertiary hospitals for uncomplicated conditions by about 15 percentage points. Now, all these are going in the right direction that the government desire. And so as a result of that, this is scaled up to the whole Ningxia province, and the national government actually has included this as a model that the whole country, especially the Western region, should learn from and try to replicate, adapting to their situation. And then we are continuing improved and refined models of similar kinds in Guizhou province now, and I'm not going to go into all the details. So in addition to how to make sure that the resources can actually be channeled into effective services, and China, like the rest of the world, is facing very similar challenges. Aging population, which Arthur will talk about, but also rising expectation. The rising middle income class have major expectation for healthcare in China that raises that fundamental question of what is the role and what is the scope that private healthcare can play and should play. And there's a very big tension in China and in India as well. Many people view private healthcare as evil. They're just coming in to make money. But at the same time, the government is recognizing that it cannot deliver and service everybody. So the fundamental question is, how can you set up the rule of game so that the private sector would actually come into healthcare, that they will be making profit, but at the same time serving social goal that the government wants to achieve. And if you read Xi Jinping's recent health conference that was held in August, one of the challenges that he mentioned is, how do you use the private sector? How do you encourage the private industry, but in a way that is promoting social goal? And in that speech, another challenge that he had mentioned is, how do you look at health in light of the cross-sector implications? In other words, how do you look at healthcare and how it relates to environment? How it relates to urban planning? How does it relate to food and agriculture policy? How does it relate to climate? So if you read his speech, the pronouncement of the August health conference, you will see that that's very central place. I'm done. But as I emphasize, these are challenges that the world faces and China faces. China is trying to learn from the world, but China is also trying to leapfrog to produce solutions that the world can benefit, with the understanding that China also have 2 unique characteristics. One is the big dominance of public sector that is actually acting like for-profit providers, and also the fact that the decision-making on healthcare is very dispersed among 8 to 10 ministries, which make decision-making very complicated. But in order to have an influence in the global context or in China, I have one view. We need to understand in a particular country situation, what is that pathway to change? I would say that compared to other countries that I have worked in, China does pay relatively more attention to evidence than other countries that I have worked in. And I am nuancing with the word relatively. And also, China actually relies a lot on experts that they consult with. Now, at the end, do they take all the recommendation? Of course, that's a separate issue. But there is serious attention to experts. And therefore, I think this is where I think that to answer, respond to Arthur's comment is, I think there's still a big role for academics to play in area studies, because by working with particular area, you actually generate global lessons as well. And China is one among the many countries that are actually more open to scientific studies. Thank you.
Thank you, Winnie. It's very, very typical of Winnie. You talk very clear, very probing, and based on evidence. You know, given the current election in America, we believe we may be living in a post-fact world. But Winnie's pointing to a different world. Now, what I'm going to do is, rather than have questions, I'm sure you have a lot of questions, but I'm going to save a half an hour at the end so we can have a real discussion. We'll just move on to Prerna's talk. Prerna.
So thank you all for being here, and thank you, Arthur, for inviting me. So I'm going to take you into a little bit more of a historical neck of the woods, but hopefully return to some of the questions that Arthur posed at the beginning.
Can you turn the mic up or something?
Yeah.
Because I can't hear you.
Yeah, let's see if it's on, is it?
I think if you move it further up,
Yeah, that'll be better.
Thanks.
So historically, one of the greatest threats to mankind has come from the tiniest of creatures, which is disease-causing microorganisms. And in the 20th century, we made remarkable advances in medical research and treatments, and yet today we continue to confront grave challenges, both from old diseases such as tuberculosis and malaria, but also from new diseases such as Ebola and Zika and AIDS. And these diseases have not only enormous economic costs in addition to the human morbidity and mortality, but they also constitute significant political challenges, as the crises over Zika and Ebola clearly demonstrate. So one of the reasons why you see the kind of international crises over infectious diseases such as Ebola and Zika is that they don't respect national boundaries. And in that way, they're quite similar to terrorism. And yet, historically, the national or political boundary that you have found yourself within critically influences your vulnerability to an infectious disease. And yet, polities with similar demographic, epidemiological, and socioeconomic conditions have actually had very different levels of effectiveness in countering infectious diseases. And the question that I want to pose is, why is that the case? And so global attention, as well as public health scholarship on this topic, has tended to focus a lot on the invention of disease-controlling technologies. And indeed, the treatments like antibiotics and prophylactics like vaccines have changed the way that we counter infectious diseases today as compared to 150 years ago. And yet it's important to keep in mind that today the gravest medical threats that we face are not from diseases for which we lack adequate technology. So think, for instance, of the single largest cause of death among children is measles. And measles is a disease for which we've long had a safe and a cost-effective vaccine. Polio, a disease that we struggle to eradicate today, again, we have a polio vaccine that we know to be effective. So for me, the question as a social scientist is that obviously the invention of these disease-controlling technologies are important, but they're clearly not sufficient. And what I want to do is focus the attention a little bit instead on this question of the spread of a disease-controlling technology. Why exactly is it that certain places in the world see the effective and rapid spread of a disease-controlling technology as compared to other places in the world? And again, if you look at social science, they have tended to focus a lot on this question of the provision of the disease-controlling technology. So questions at the national level about how differences in levels of economic development, the ideology or the nature of a regime, whether you're a democracy or a communist dictatorship, all are theorized to influence how well you provide a disease-controlling technology. But what I want to argue instead is that while again this is important, what I argue is arguably more important and relatively underemphasized, is this question of an adoption of a disease-controlling technology. And so the question that I want to ask, particularly in the context of a comparison of the cities of Canton and Calcutta in the 19th century, is why do you see the more enthusiastic adoption of a disease-controlling technology, which then downstream influences your ability to counter an infectious disease, as compared to another place where you do not see the same degree or level of enthusiasm in terms of its adoption? So what I want to begin with theoretically is the idea that a biomedical technology rarely exists in a void. And when it arrives in a community, it often encounters established beliefs and ritual cultural medical practices as regards a particular disease. But rather than seeing these as an opposition to each other, the idea being that a biomedical technology, for instance, antiretrovirals, need to succeed by displacing a traditional understanding and medical system associated with it, what I want to argue is that rather than seeing this as a kind of a domination game, that a biomedical technology is actually more likely to succeed in a community if it can map onto and align itself with the established ways of understanding and the traditional practices associated with the disease. And before I get into the empirics of the two cases that I want to talk about, I just want to kind of flag how actually this is related to what in social psychology is known to be a human preference and striving for cognitive consonance. So the idea that we as humans understand things better and are more amenable to them when they're embedded in a vocabulary of the familiar. So Festinger, who is known for his work in cognitive consonance theory, had once, he says that there's a tourist guide for Americans visiting France, and it talks about how they should broaden their culinary experiences and try frog legs. And he says how, it says very clearly, frog legs taste just like chicken legs. And the theory here is that for new information to be understood as useful or helpful, we must find schema with which to link the new stimulus to previously understood experiences. And this is based on thousands of experiments across social psychology, theories of communication, marketing research, as well as education, and most prominently in the work of Daniel Kahneman in prospect theory, in which he talks about cognitive ease and talks about how statements are more believable when they're linked to established beliefs or understandings rather than seen as a radical rejection of them. So I'm going to quickly, having presented the research question framework, talk a little bit about why I want to talk about smallpox, Canton and Calcutta, and then talk about the alternative explanations as well as my own hypothesis for why it was that the city of Canton so enthusiastically and rapidly accepted the smallpox vaccine in the 19th century as compared to the city of Calcutta, and hopefully end with conclusions that bring it back into the realm of contemporary public health. So smallpox is the oldest and, by the accounts of many medical historians, the deadliest disease to afflict mankind. You were quite likely to die, about a 40% chance, and if you did survive, your face was rendered this lunar, pock-marked landscape of the kind that you often see in grainy old photographs. But in addition to being and having this kind of horrific nature and a kind of landmark status, it's also the site of the world's most triumphant achievement in medicine and public health. And this is from the WHO's own history, in that it's the only human disease that we've been able to eradicate. And at the heart of this, of course, was the smallpox vaccine. Ironically, it's because of our very success in eradicating smallpox that we are now uniquely vulnerable to it. So it's also emerged, interestingly, as a contemporary threat, as an agent of bioterrorism. So this is a photograph of George W. Bush announcing the plan to vaccinate all American first responders and members of the armed forces against smallpox in 2002. He received the vaccination himself as the Supreme Commander of the Armed Forces, and everyone who was serving in the army at that point in time was vaccinated, and this had to do with the threat that had emerged in the wake of the use of anthrax. So all of it to situate smallpox as a disease that, while it thankfully is no longer with us, is clearly not forgotten. So what I want to do is kind of situate the comparison in terms of a city sub. So this is part of a larger book project, I should say, which compares the history of public health campaigns through the 19th, but into the 20th and 21st centuries in China and India. But what I want to focus on today is a comparison of two cities that I want to argue are remarkably well matched on a number of indicators that you would think should influence the adoption of a disease controlling technology, such as the smallpox vaccine. So they're both cities that are coastal cities, riverine cities, in very similar tropical, subtropical climatic conditions. They're also cities that in the beginning of the 19th century and into the middle were large, densely populated, growing cities. Their populations swelled mostly by male selective migration, which led to highly skewed gender ratios. Both cities with a high degree of linguistic and religious and cultural diversity broadly, as well as, in the case of Canton, a fair degree of ethnic conflict. And also two cities that both relative to the larger empire in China and colonial India were two cities that were relatively literate. And this you can imagine as being a potentially important explanation in trying to understand why people adopt a vaccine or don't. So they're both cities that have remarkably high degrees, particularly of adult, but also female literacy and a flourishing print culture. They're also both cities with a vibrant commercial life. They're the most important that should read most important Indian commercial city. They're also two of the largest cities in the world at this point in time. So European cities pale in comparison to the splendor of Canton and Calcutta at this point. What's also interesting, and I couldn't resist the temptation of showing you this photograph, which is actually from a museum very close to Boston in Salem. And it's a photograph of the three Money brothers. They were actually called Money. Their father was in the East India Company, but what I would just want to alert you to is where their fingers are pointing. So the youngest brother, Robert, is pointing to Canton, and the eldest brother, William, is pointing to Calcutta. And so when I actually saw this photograph, this painting in the museum on a recent visit, I think I was by many years the most excited person in this museum that has been in existence. It's actually one of the oldest museums in the world to ever exude the degree of excitement that I did when I saw this painting. But what this painting indicates you towards is the fact that at this point in time, Canton and Calcutta are basically undergirding the entire global economy, and in particular British imperialism. And at the heart of it is the European unquenchable thirst for tea. And so they get the tea from Canton, and so of course they pay for the tea that they're getting from Canton via the silver that they're mining from India. But of course at some point in time, India's silver dries up, and so they have to find something else with which to pay for the tea that they continue to need from Canton. They are at this point in time shipping hundreds of tons of tea into European cities, which are all being consumed and leading to the profits of the East India Company. And so they realize that, and of course famously, the Chinese don't need any of their imports, and so they're at a loss as to what it is that they can give Canton that will allow them to continue to pay for this tea. And of course, infamously and sadly, this becomes opium. And so of course, all of this opium is cultivated, large amounts of it are cultivated in the hinterlands of Calcutta and are shipped out of Calcutta on special ships called East Indiamen that take the opium to Canton. So simultaneously, it's ruinous to the Chinese health, both of the body politic and of the body, and also of course ruinous to Indian Bengali health, because it of course the cultivation of opium replaces the cultivation of essential food commodities. So all of it to say that the two cities, while being important for comparison, are also intricately linked at this point in time. While they are very wealthy cities, they're also cities with a high degree of inequality, in which a wealthy indigenous merchant class cohabits with a large poor migrant underclass, which live in often squalid conditions that are seen to give rise to a large number of infectious diseases. They're both politically important cities. Calcutta is the capital of the British India at this point in time, and Canton, which is of course administratively divided between the Nanhai and the Panyu counties, is the administrative center of the South China region. They're also cities with high degrees of mortality and a high infectious disease burden. But even more critically, from my point of view, they also have very similar histories of smallpox. They're smallpox endemic cities. And historically, the way that they have dealt with smallpox is also quite similar, in that smallpox is seen as a visitation by a smallpox deity. I just want to flag that this is not peculiar to the East. Europe has a number of disease deities at this point in time, St. Nicholas and a number of other disease deities that emerged at the time of the plague. And these are representations of Shitla and Tosh and Nyang Nyang. Surprisingly, a lot of art historians have found a fair degree of similarity across the representations of these two quite popular and democratic deities. But there are also very similar rules and rituals about how you deal with smallpox. Most critically, they have a very effective and well-developed prophylactic called variolation. How many of you here in the room are familiar with variolation? Okay, great. So maybe I'll just, so it's the idea is actually very similar to how one might think of how I understand, take cocaine in the Chinese context. So you would snort up old smallpox scabs up your nose. So the idea is the only thing that you knew was that once you got smallpox, you never got it again. So say Arthur got a case of smallpox, it was known to be quite mild. A doctor would very clinically and in a very systematic fashion take some scabs from Arthur, grind them into powder, keep them for a couple of seasons so they decline in effectiveness, and then I would, under the guidance of a physician, snort this up my nose in the Chinese context, in the South Chinese context. In India, it would actually be inserted into your skin, much like a contemporary vaccine. The idea being that now I have gotten, under a controlled condition, a relatively mild case of smallpox, and this is going to preserve me from a kind of full-blown case. I mean, interestingly, Edward Jenner, who is credited with the invention of the vaccine, his father was a variolator. And variolation came to Europe, the debate is still on, either from India or from China via Turkey, and led to huge decreases in mortality from smallpox in Europe. So the interesting thing is that the invention of the vaccine is usually seen as a European invention, but Jenner himself, in a way, his contribution was simply to realize you didn't need to give people smallpox, you could instead give them cowpox. And so his observation that cowpox maidens were beautiful because they never had smallpox was because they got because they got cowpox, and that made you immune to smallpox. And so the general idea being that this case gave you protection from smallpox. And so this was the case. These were both very popular practices in 19th century Canton and Calcutta, and it of course had gone to Europe and led to decreases in mortality by then. So all of this is to kind of set up for you that these two cities are very similar on a number of factors that you might think would influence the way in which the smallpox vaccine would be accepted. The other interesting thing, of course, is that the smallpox vaccine comes at almost exactly the same period of time to these two cities via the same actor, the East India Company. And yet, and that is the crux of my question, you see a critical difference in that this vaccine gets readily and enthusiastically accepted in Canton, such that by 1850, your vaccination rate in the city of Canton is 85%, while in the city of Calcutta, it's between 1% to 5%. And the question that I want to ask is why, given these similarities that I have just tried to lay out for you in an admittedly bare bones fashion, why is it that the Jennerian vaccine for smallpox spread much more swiftly in Canton than it did in Calcutta? And I'll go very quickly. As political scientists, we care so much about alternative explanations that it can get a little tedious for an audience. But the idea is that in order to show you that what I think is important, I need to first show you what other people have said is important and why I think it doesn't actually matter that much. So a lot of scholars and historians of medicine have argued that this had to do with differences in technology. But again, this is why the comparison of Canton and Calcutta is such a good one to me, is because because the challenge of maintaining lymph in a subtropical hot and humid climate was the same in both cities. Again, if you look, for instance, at the institutions for delivery, the big difference, and I'll get to this in a little bit, is that the initiation happens via local merchant associations, the Kohong in Canton, and via the colonial government in Calcutta, and that's obviously a big difference. But the way in which this happens, by a series of vaccinators, a combination of vaccination available through dispensaries for free, and individual traveling vaccinators who charge a nominal fee, the structure of the way in which it's delivered is quite similar. The critical difference, I argue, is that, of course, there was it was the degree of popular mobilization. So it has less to do with technology and the institutions for delivery and more to do with the popular reaction. So why is it that you would see these differences in popular reaction? And again, the key argument that I want to kind of argue against, in a way, is one associated with the subaltern studies school of historians in the South Asian context, which is that Calcutta is a colonial city in the way that Canton isn't. And so the idea that you would have a European intervention, you obviously counter this important and influential argument that it's resisted because it's a tool of empire. It represents a colonization of the body, and it is resisted as such. This is by far the most dominant way of understanding the resistance to vaccination in Calcutta. But what I want to argue against this is that a lot of other colonial interventions, including in medicine, are enthusiastically accepted. And the question of temporality. Smallpox is about 100 years before the draconian plague interventions that are resisted for a range of political reasons. I often, point out to my class in the politics of India that the only serving colonial official in India who was ever assassinated was the plague commissioner of the city of Bombay. And that is a good indicator of the degree of both the intervention but also the popular resistance to the plague quarantines. But this is not the plague. This is about 100 years before the plague. And the colonial state is still in its early days. It hasn't quite developed either the infrastructure or the ideology of the kind of intervention that it becomes associated with later. Similarly, it's not the case that a European intervention would be at all enthusiastically accepted in Canton, given that this was a city in which there was a deep suspicion of foreigners, they were called foreign devils, big-nosed barbarians, and of course, as I mentioned earlier, the primary product with which the East India Company was associated was opium. And so again, what I want to argue is that it's not so easy as to think of this difference in popular enthusiasm by reference primarily to British colonialism. Similarly, a lot of colonial reports, if you read them, they talk about the fact that this should have been resisted because, of course, both Canton and Calcutta are highly conservative cities in which, obviously, these are going to meet with opposition from prejudice. But these are, again, considered constant in Canton and Calcutta. It's an inefficient technology. There's a violation of societal taboos in both instances. This is not an efficient technology in the early 19th century. And also there's, in India, there's a violation of a caste taboo. But in China, there's the fear of leprosy, which at this point in time is by far one of the most important fears. And so in both, there's a violation of a taboo. And it's not at all clear why, again, this should have been the easy explanation for differences in mobilization. So what I do want to argue is that why I think vaccination was resisted in Calcutta but accepted in Canton was because in Canton it was embedded within a traditional method of understanding and of ritual and cultural practices associated with the disease, while in Calcutta it was seen as a rejection of the traditional understandings and practices. And I'll tell you what I mean in a minute, but let me just tell you how quickly it happens in Canton. The Surgeon General of the East India Company writes a pamphlet in English on vaccination, which is translated into Chinese by Chiu Shi as In Tou Liu. And it is ostensibly a translation, but as a number of scholars have pointed out, what it essentially does is it sinicizes the Jennerian vaccine. And it does this in about 5 or 6 important ways. The first is that through the title, it suppresses the British origin. It uses the titling and writing style of traditional Chinese medicine texts. It adds, and when Jenner is informed of this, he is heartbroken because he says, the entire point of the vaccine is that it does not rely on ritual and culture, and there's no theory. You just have this one-shot vaccine, and that's it, you're done. And yet, all this unnecessary material is added in which the idea of how vaccine works is embedded in the idea of the taidu, the fetal toxin, and it's the idea that it's also now a move from nasal insufflation into and basically an incision into your arm is justified in terms of meridian acupuncture. So this is a page from the In Tou Liu. And Angela Leung, who's written about this particular text, talks about how it was graced with engravings of children with meridian points on their arms, and this disguised impeccably the breaks from mainstream traditional practice. I also like the fact that, of course, they introduced a Chinese baby, a child, and I can talk about this text, which I've become increasingly fascinated by. It has about 67 different editions, all with prefaces from local gentry, and it's actually quite a beautiful text. I had a chance actually to see an original in the Sun Yat-sen University this summer. But all of this is to say that basically it also adds pre- and post-op dietary protocols and herbal medical formulas, neither of which was at all important or necessary to the vaccination. So this is the kind of, this is the critical thing, is that the reason why this is shaded in gray, and I'll show you what it looks like for India and for Calcutta in a second, is that so vaccination gets embedded in a centuries-long method of dealing with smallpox, which includes the theory, the treatment, the rituals, the propitiation of the goddess, the timing of it, the diet, the regimen of care, and the medicines. So vaccination, rather than being this kind of European import from Jenner, becomes yet another intervention, an improvement within a traditional understanding of how this disease had been understood for a long time. In Calcutta, on the other hand, when you read colonial reports, and most of the Indian historiography at this point in time is through colonial reports, so I began to read these colonial reports to understand, well, what was the nature of the opposition to vaccination? Why were people refusing to get themselves vaccinated? And again, you hear this hand-wringing. You can almost kind of hear this frustration in the colonial reports, but how it has to do with the fact that there is no puja. So puja is the word for a prayer. And so they talk about the fact that people object that there's no prayer, there's no goddess, there's no ritual, there's no diet, there's no ceremony. The vaccinator just comes once and then disappears. What am I supposed to eat? What am I not supposed to eat? When can I bathe? When can I not bathe? There's absolutely nothing. Yeah, so I'm almost done. And so this is what it gets to, is that rather than that kind of continuum in the shades of gray that you see in the context of Canton, in Calcutta, vaccination is seen and is presented as this break. It's seen and it becomes understood rather than as a propitiation of the goddess, it's seen as an attack on the goddess, but also that all the rituals, the timing, the diet, the regimen of care, and the medicines that were continued into vaccination from variolation in Canton do not exist in Calcutta. So the interesting thing is, when vaccination was accepted in Calcutta, very interestingly, it was accepted exactly as variolation had been. So against the state, people decided to choose an auspicious day. They observed the old ritual and dietary taboos. They did not employ, they employed a vaccinator, but they employed a priest in addition to the vaccinator, and they invoked the goddess of smallpox, and they thanked the goddess rather than Jenner for the child's safe passage. And this is a particularly important passage for me because, of course, it comes from David Arnold, who is usually associated with the subaltern studies school, in which he talks about the fact that this is, so it's in a way a kind of someone that I argue against, who I think is also simultaneously presenting evidence for what I think the real causal driver for the difference is. So I just want to end, actually, by just talking about the fact that I've taken you into a little bit of a kind of historical neck of the woods. And the way that I found myself there was because I began this project by comparing Maoist China and Nehruvian India. And in this room and in other rooms in CJS South and in the Kanafar building where I had an office, as I began to present initial thoughts on this project, I got a lot of pushback, mostly from my colleagues within political science, that you can't compare Maoist China and Nehruvian India because, of course, as political scientists, we know that they differ critically on regime type. You have a democratic republic and an authoritarian communist country. And so that there was too much of the difference between these two that was driving it. And so it pushed me to a time when I said, okay, so let's look at China before communism and India before democracy. But what I think this particular comparison pushes me towards is this idea of how I think it informs, but is also informed by a lot of the contemporary debates within the public health scholarship. I think in terms of scholarly debates, but I won't get into, I think it makes us re-question this idea of tradition versus modernity. But it also, I think, in terms of where area studies intersects with global studies, as a political scientist, I found myself reading a lot of anthropology, a lot of history of medicine, a lot of sociology, but also it's interesting to me that a lot of the contemporary debates in public health, for instance, happening along the trajectory of HIV/AIDS in South Africa, mirror what was happening in Canton and Calcutta almost 250 years ago now. And so now, if you look at the way, for instance, that the Gates Foundation deals with traditional healers in South Africa, they went from thinking of traditional healers as an impediment to the distribution of antiretrovirals to actively working with traditional healers as a way to distribute and, in addition, prescribe their own herbal medicines in the attack, in the battle against HIV/AIDS. And the idea being that if you embed public health initiatives in an understanding, in a cultural understanding, in an indigenous understanding of this disease, and if you work with local providers and with people who don't necessarily follow the same idea of biomedicine that we do, this is a more effective way of distributing a disease-controlling technology as compared to a way in which we thought of culture or an area's culture as an impediment to our global public health campaigns.
Oh, Prerna, thank you so much for that. It was great. Do you think you can help me get to mine over here?
Yes, absolutely. I'm happy to put it on.
Well, I've left a little time for myself, and then we'll have lots of discussion. So,
you just need to press these buttons, right?
Yeah. Great. So, use this again so that you can hear me. All right. So we began with the four framings that I gave for understanding the relationship of global and area studies and how health and aging and medicine and science change what China studies have been into a different kind of China studies. And we have started with the healthcare system. We've turned now to comparisons, arguing that comparisons, as they relate to health, are very important ways of understanding. And now I want to just look at aging, elder care, and mental health in China, which is unavoidably centered in global issues. So as I mentioned earlier, we do live in a post-fact time in the United States, but it's good to begin with facts. And we're in the middle of a I don't think Donald Trump has taken a position on this, but we're in the middle of a major demographic change in the world, a change toward older societies. In 2040, Japan will be the first society in the world in which 40% of the population will be over 60 years of age. There's never been a society like that. And Japan, which has, I would argue, the best elder care system today in the world, can't possibly maintain that in the future because of the cost and the limited manpower that is available. But if you look on here, you'll see it's not just this aging phenomena is not just happening in Japan. Virtually all of Asia is experiencing this, and in 2040, somewhere between 25 and 30% of the Chinese population will be over 60 years of age. Again, producing a very different kind of society with different needs. And for those of you who have a little trouble about the why is it that over 60 matters, I'm over 60. You wouldn't have guessed it, but it's true. And I'll just tell you that over 60, you average one chronic disease, at least in American society. Over 65, you average 3 chronic diseases. Over 70, you average 4 to 5 chronic diseases. Now, by and large, these are not life-shattering chronic diseases. They're arthritis and hypertension, but they can be deadly, as hypertension can, for example, lead to stroke. So this is a different point in our lives. But this change is happening in China, for example, and not just in China, in which, at a time in which, as Winnie has suggested, the support system, and here I've emphasized the social security system, is not going to be adequate to meet demands unless something important happens. And this is just a stark, get my glasses, stark example of this. It's seeing elderly who are unable to get by, either protesting or literally falling apart in public settings. And I want to show you just some, this completely supports what Winnie says. This is the example of China's great increased expenditure on healthcare. This is just an enormous change. And although, as Winnie indicated, China has no primary care system and it is desperately trying to build it right now. And I think this is, again, a sign of, at a time of China bashing, a sign of China doing things that is quite extraordinary in global perspective. This is why, as you can see, about over 7 workers support a retiree today. In China, in 2050, it'll be just a little bit over 1.5. And now, why is dementia? Why are people so concerned about dementia? It isn't that we haven't had dementia before. It's because so many people now are living into an age bracket when the prevalence of dementia, not just Alzheimer's-related dementia, and Alzheimer's is only one form of dementia, but when the prevalence of dementia becomes very substantial. So, and these are very conservative figures from China. They suggest that about a third of people over 85 years of age develop dementia. But actually, the figure from the United States is higher. Yeah. For those of you who find this a consoling figure, in our society, it's over 50%. You live to 85 years of age in America, 50% of people have some form of dementia. And this is why around the world there's such great concern about dementia. And I'm using one form of dementia here, Alzheimer's disease. And that is that the yearly cost per patient for Alzheimer's disease is simply enormous. And I can actually tell you this at a personal experience, just to get a sense of what Winnie meant when she said that these are problems that people face, serious health problems that can bankrupt you or in which you can't possibly pay for services. In our country, in the United States, in 2011, in the last 6 months of my wife's life, she had Alzheimer's for 10 years, I spent $150,000 in the last 6 months of her life. And I had long-term health insurance, which covered $50,000. Okay? Now just picture that for people in our society who don't have that kind of insurance or who don't have the ability to pay $150,000. And now go to China and just think of that for ordinary people in Ningxia or for middle-class people in Shanghai, of the burden of care at the end of the experience of Alzheimer's. And you saw the rates of hospitalization going way up in China. That's where so many Alzheimer's patients are ending up. They're ending up in Huliyuan, sort of in a storage facility as it is, because families simply can't afford at that stage to take care of them. And indeed, something extraordinarily interesting is happening in China today, which has both a positive and negative effect. I'm going to try to move very quickly, so the slides may bear no relationship to what I say, since we're running out of time. You'll forgive me about this. But as the chair, this is why a chair should never be a presenter. You know the story about what happens, by the way, for those of you who haven't had the experience, when the chair turns to the presenter, as I did to Prerna, and says your time has run out, etc. There are three things you can do. You can talk very quickly, you can duck your head, or you can say, and this is most effective, well, I was just getting to the point about sexuality, but I guess I'll have to stop. And then the audience demands that you continue. And anyway, the point I want to make now is that as Chinese economy is seeing a movement of companies from extraction industries and manufacturing into the service sector, elder care is becoming a huge area. So, for example, Wang Shi, the head of the Wang Ke, the Venki Corporation, which owns 2.5% of all residential real estate in China, has gone into elder care in a very big way, and has created, for those of you who want to see elder care at its best sense, in Hangzhou, a fantastic elder care community for intellectuals and musicians, a sort of high-end elder care, but a great example of what one can do if one places quality, suzhi, above simply making money. But that's not what, in fact, is happening in China today. And I had a visit when I was head of the Asia Center about a year and a half ago, from a group of businessmen led by the vice mayor of Nanjing, who said very bluntly to me, the opening line was, how do we make money off of elder care? And my feeling is that as a business, they should. As we heard, China's turning toward the private sector to deliver care. They should be able to make a return on it, but they've got to start with the issue of quality. It has to be quality care. So, because so much of this also ties to the cultural issues that Prerna did such a nice job in bringing out for vaccination for smallpox, I just want to point out that one of the interesting aspects of elder care in China that is an example of drawing on the tradition in the contemporary world in a very effective way are ideas of yanglao, yangsheng, this idea of nurturing not just the aged, but nurturing life. And therefore, we call this active participation. And I have done extensive research on this with my colleague Chen Heng Tu, and with our colleagues in China, with Jingjun at Tsinghua, with Pantianshu at Fudan, with Shaoshuiyuan in Changsha at Shangya Yishuiyuan, and with Chengyu in Guangzhou, showing how useful this approach is to active engagement of the elderly in their own care and in care of family members. I'm not going to go through all these policy approaches. They simply illustrate the fact in the research literature that there are many things that can be done. Okay, time is running out. I'm going to switch to another theme. I'm covering several here. Mental health. Now, one of the interesting things about Chinese society and about other societies as well is that in the period of very rapid globalization and economic development, many of the psychiatric disorders go up in rates. Part of this is due to the fact that psychiatric evaluation becomes better, and those evaluations become more culturally appropriate. Services are present. There's a reason to try to diagnose people. And so part of it is inflated by better science. But there's no question about the fact that it's not just better science, that the rates go up. Now, when I first went to China in 1978, I did a study in 78, 80, 81, 83, which was probably the first study of the individual effects of trauma during the Cultural Revolution on intellectuals, cadres, and workers. I published that in 1984 in my book, Social Origins of Disease, Depression, Neurasthenia, and Pain in China. And at that time, in psychiatric clinics across China, 1% of patients had a diagnosis of depression, and there was virtually no data from population-based data. And in medical clinics, that is internal medicine or primary care clinics, there was 0% diagnosis of depression. Today we know, and I'm just picking off a study of a former student of mine, Michael Phillips, who I think is the outstanding researcher with his colleagues in Shanghai on mental illness today in China. The overall rate is almost exactly the same as in the United States. So 1980, a rate that is almost off the table is almost no rate of depression. Today, the same rate as in the United States. And this, by the way, is mirrored by other rates. So mood disorders means, for those of you who don't know, depression, I'm sorry. Anxiety disorders, substance abuse disorders, virtually all the disorders showing rates now that are the same as in America. But look at this difference in 2009. Among individuals with a diagnosable mental illness, of whom 24% were moderately or severely disabled, only 8% had ever sought professional help, and only 5% had ever seen a mental health professional. And at this particular time, remember, Winnie said that the overall GDP input into health was about 1% earlier, and then now it's over 3% for China. Well, when it was 1%, that 1% of GDP going into the general area of health, less than 0.1% of that went to mental health. Okay? And yet mental health problems, here I don't have time to show you this, but let me just tell you that I ran a big conference at the World Bank with my former student Jim Kim in March. And mental health problems are the most costly problems of all health problems. And across the world, the same set of issues are arising: limited access, limited utilization, poor quality when it is utilized, and outcomes that are really not useful because they're so low in effectiveness. So based on Phillips and colleagues' data, it would mean that in 2009, about 173 million people in the country in China had a mental illness. That sounds high to you. Let me just tell you, in the United States, the lifetime prevalence of mental illness is almost 50% of the population, and at any given time, 1/4 of the population has mental illness. 158 million of these had never received any kind of professional help. I don't mean just a psychiatrist or psychologist, going to see a physician, going to see a traditional Chinese medicine physician, any kind of professional help for an enormously costly disease. Now, suicide, just as another issue. China released, the suicide rate in China was neighbor, was not publicly available until the 1990s, starting in the late 80s and 90s. And China had a suicide rate that was 2.5 times the American rate at that time, in the 1990s, when it was finally released. And it was a surprising suicide rate by North American and European standards, but perhaps not by Indian standards, although the Indian data is less clear, in that it was a rate higher in men than in women. Suicide is a problem of men in the United States. In China, it's a problem of women. More than that, suicide was a problem of rural women. Rural women had 3 times the rate, rural young women had 3 times the rate of suicide in rural China as in urban China. Okay? Now, and if you're interested, we can go into some details here. I'm just showing this because, I don't know what happened here, let's see. Because the great change, if I have it here somewhere, let's just forget this. The great change in suicide in China, and one of the great public health victories in the world, is that over the last decade, China has reduced by half the number of cases of suicide. No other country in the world has done this, by half. And the reduction is suicide in young women and suicide in rural women, young women. And it has 2 components. One is that with loosening up of the hukou system and the ability of young women in rural areas to move to cities to be with their spouses, the pressure on them has been lessened and the suicide rate reduced. And the other one is that China introduced a safety cap on insecticides and herbicides. And the impulsive taking of an insecticide or herbicide was often the reason for suicide in rural China. So now it's a more difficult thing to do. You have to think about it for a bit. China's also had a new mental health law. So China never had a mental health law before, which actually protects the rights of the mentally ill. In the past, if you were had any kind of mental health problem, you could be placed involuntarily in a locked psychiatric unit by your family, or in fact by a local cadre. And this routinely happened to people. Now there's a protection of the mentally ill, taken very seriously. I've been in hospitals in very poor areas of China in recent years, and I can tell you there's great seriousness about the rights of the mentally ill, which is an astonishing change in how the mentally ill have been treated in Chinese society. There's an increase in the healthcare financing structure for mental health problems. There's the development of more professionals and of higher pay for professionals. Many of you realize that the last 10 years we've seen what's called sorry about that, a Xinli Re, or psycho boom in China, that's associated with lots of general interest in psychology, and which in a book called Deep China, which I did with a number of my former students, we attribute to a deepening of the sense of the person in Chinese society and of concern for personal issues like mood disorders. I think this is just going the opposite way. Well, I think with that, I think we'll stop. I can't seem to get away from the suicide thing. Maybe just turn it off. I wanted to talk just briefly about why. So why is it that health opens a different window on Chinese society? First of all, it shows a much more encouraging and much more positive view, I think, of the policy development and politics of China and the developments that on the ground of services for people. China has many problems, as we've heard, in the health domain, but it's astonishing how much has changed over the last 3 and 4 decades. An astonishing set of changes. And it's reflected in Chinese mortality rates. Shanghai has a better mortality rate than New York City has. Beijing has a better mortality rate than Boston has. For those of you who think that they were close in the past, they weren't. If you go back all the way to 1949, in 1949, half of all babies born in Beijing died before the year of one years of age, or in a Chinese setting, 2 years of age. Almost no country in the world has ever had a rate of 500 deaths per 1,000 live births, just to indicate what the mortality was in the past in China. The mortality greatly improved during the period of radical Maoism. It may have been one of the great features of radical Maoism was the improvement of health. In my personal view, the unprecedented reduction in poverty is largely responsible, for the improvement of health in Chinese society and the building of the middle class, which is, I think, one of the great developments in China, is responsible for what Winnie called the demand for higher services and for better services, the concern for quality, the refusal to accept poor care, and the concerns for what the future will hold, especially as it relates to elder care and aging. So therefore, I think in a society that has a press that seems to systematically bash China, I think the mental health, aging perspective shows not just the challenges that China faces, but the remarkable developments that it has encouraged and brought along. And also, it's a domain where collaboration with those of us who do research in this area is not just important, but is encouraging and very much in keeping with Steve Orlean's comments last night, is a sign of how the U.S. and China can work together. Because, as we've heard, these are problems that are shared. Not all of them, but many of them. And the solution frameworks that we've worked out may not be the best, and learning from the Chinese may be indeed something important for us. For example, we have a rising suicide rate in the United States. We could learn from the Chinese how they've controlled how they've worked to control certain kinds of suicide. Similarly, in the United States, we have a chaotic non-healthcare system. Okay? I think certain of the things that Winnie talked about, like, for example, universal health care, which virtually all countries except the United States have signed on to as a goal, the right to health care and the provision of universal health care. I think this is something enormously significant that we can learn from. On the other hand, we have things that we can teach still, and teach in a non-colonial way. And the Chinese know this. And the building of a primary care system is something that we've done in this country. We have an extraordinary primary health care system. And China is trying to learn from that, from both our successes and our failures in this regard. Hence, what am I trying to say? That the four things that I started with, basically. One, that there will be no social sciences in the future unless they contribute to the improvement of society and the improvement of people's lives. That two, the comparisons between countries can tell us something important about health. Three, that somehow area studies and global studies need to come together. We need both the deep understanding of cultural issues, language issues, and history that Prerna illustrated for us, and also Winnie illustrated for us, and also we need the global science part. We need the global science of the environment, of aging, of health, of trade, of finance. It's the coming together of the two that allows us to do a couple of things. One, to improve society and people's lives. Two, to have evidence-based understandings that are important, not simply interpretations, but interpretations based in evidence. Three, that this enables us to participate in global understandings and to project those understandings in ways that can be useful locally. And then I think the fourth remark that I made was that this change would change China studies. And I think I heard, if I heard it right, and he's here in the room, he can correct me if I'm wrong, I thought I heard our wonderful new director of the Fairbank Center say that there's a new way of doing China studies, in which history and language and culture were coming together with new understandings, new ways of looking at China. And I think this panel was meant to suggest some of, one area, the health area, as a new way of doing that. So let me end at that point, and let's bring our panelists forward here. Please come around here, Winnie, and we'll open it up for, I'm sure there are lots of questions. Let me just see how much time we have. We have a half an hour.
No time yet.
About? Yes, please.
Yeah, a question to you. You mentioned the Hangzhou Senior Care Center is a quality center.
Yes.
Can you elaborate a little bit how you measure quality? Because, like, if I use a restaurant example, you have a lot of money, you go to expensive restaurants. Yes. But then if you have less money, you can still find some good restaurant.
Yes. I'm not saying that that Venki project is the only way to do successful aging in an institutional setting, but I'm saying it's an example of high quality because of first of all, the facilities, beautiful facilities. The comparable facilities here, if you know nursing homes in the Boston area, would be the Dedham facility, Newbridge on the Charles. Beautiful setting, lovely apartments, movement from assisted living into nursing, skilled nursing as a sort of seamless movement, the building of a community services, keeping people first in these individual apartments as long as possible before they have to move into a nursing home setting, involvement of families in this, and people who feel that the experiences they're having are really good experiences and want to be in those. Winnie.
I want to comment on this in a way that's relating to the opening of what I was talking about, China's healthcare reform, which is to assure affordable and equitable access to healthcare for all. And in the case of elderly care, I think at this moment the challenge is you have the private sector catering to the very rich, which is what Hangzhou, what you were talking about, and the government providing the very, very minimum to those who are really poor. And the quality of those services are bad. And I think what China is facing with the rapid aging population is, what do you do with the middle?
Yeah.
How do you bring in the private sector in a way that they still have to make profit, but at the same time they can serve the social good to make something affordable? That's the fundamental problem. And I don't think it is a problem that China faces alone. Many countries face the same problem, United States. But I think this problem is more acute in China because the increase in aging is faster in China than in many societies. And partly it's also exacerbated by the fact that China has a one-child policy, and the traditional reliance on the family all of a sudden is gone.
Yeah.
So what is the right kind of care that can cater to this population? I think it's actually a fascinating area to study and has a lot of implication, if not globally, at least in the Asia region.
Let me just say one other thing about this. Attitudes are changing in China, again, in the middle class, about institutionalization. And that is largely driven by the elderly themselves. So there have been a number of surveys that show that elderly in urban settings like Shanghai, not in necessarily well-to-do, but sort of lower middle-class settings, but where husband and wife work outside the home and no one is there during the daytime. Frail elderly no longer want to be at home because they have no one to speak to during the day. They have no engagement with others. And now there are some model for, again, the lower middle class or working class or poor people. For example, a great one, if you want to visit one, aimed at poor people, is the Lin Fun Yiyuan, which is a Jiedao Yiyuan, which is just a street hospital in Shanghai, just as has a remarkable program for the aged. But let's have other questions. Yes.
We just got an interesting. I have a question for Professor Winnie. So
Winnie.
You just talked.
Just a little louder.
Okay, we just talked a lot about the I call it the service and reform of the China medical system. But I think, my personal view, I think the finance end of the reform is still very important. My question is related to, currently the China medical insurance market is relatively monopolized by the state-owned insurance companies, and the low efficiency of these companies, because they manage most of the insurance input from the government side. So I think it will have a very big influence or negative influence on the long term of the China's medical reform and its the long-term development.
So a lot of our work is actually related to financing, because every reform starts with mobilizing money. Then the next question is, how do you use the money effectively? So what I was presenting earlier was relating China's healthcare reform, which is the starting point is the government has decided to invest on how much money, and therefore how do you make it more effective use of service. So you are talking about the room and the scope for private insurance. Is that the case? Because insurance in China is actually not dominated by state-owned enterprise, enterprise insurance. It's actually government-run, which is two separate things, actually. Now, the fundamental problem that China is facing with these government-run insurance is that, yes, as you pointed out, many of these government-run agencies actually is equally bureaucratic, and most of their concern is about controlling the budget rather than improving quality of people's health. And part of the reason is because much of the money is actually controlled within the Ministry of Human Resources and Social Security. It is a ministry that is very, for historical reason, very concerned with balancing the books, right? Because it's about Social Security, making sure that money collected would not be less than money that is paid out, and with very little attention to quality of care. And so you bring up a point which is, again, the world's debate. The world's debate is, should a social insurance program be actually managed and run by the government, or a quasi-public organization that is actually separate from the government? The world is tending towards a quasi-public organization that is not part of the government, but is still public, rather than for-profit private. But not many countries have been able to do it.
The other thing about health insurance is that if you look at the aging issue, the issue is long-term care insurance. And we don't do much in long-term care insurance because insurance companies see no gain from it, and governments don't like to do it. It's so costly. And China's going to have a major problem, don't you think, Winnie, vis-a-vis the, even thinking about long-term care insurance? How about, yes, Joan.
Yeah, so I wanted to ask in the mental health realm about the left behind children issue, which is just a huge problem facing China right now. These are the kids of migrant workers who migrate to the city and stay behind, with the grandparents. And I know the Ministry of Civil Affairs is now kind of tasked with this issue and is looking at how to set up a social work model, possibly through the school system. But given the enormity of the issue and the scarcity of mental health workers, as you pointed out, what are your thoughts about how best to reach these kids and the early intervention models on that?
Just to underline the reality of this, Winnie, maybe you want to talk about the study we did in near Jinan.
Go ahead.
Do you want to say something?
No, not yet.
Okay. Well, we did do a study together, believe it or not, which demonstrated the problem, that there were villages where there were just old people and kids, right? And they were not doing too well. And so this is a real problem. Do you want to comment at all?
I mean, sorry, both the old children and the kids were not doing well?
Yeah, neither group was doing well in research that we did, either health-wise or socially.
So there are a lot of left behind children and elderly in the rural areas. And for children, I don't have the statistics. For children, I don't have the statistics, but Joan, I don't know if it is more a mental health problem or is it more of a development problem.
Yeah, stunting.
Health problem.
Could be
I think
both.
that the current, the most recent study looked at very high rates of depression and anxiety among these children. And of course, there's the issue of abuse as well, but neglect and abuse. But it's definitely within the mental health realm.
I haven't studied it again, but putting on my sort of like cross-sector analysis hat, I would say this is not an issue that belongs just alone to the health system or the Ministry of Health. This is a broader development issues. is related to childcare support, is related to labor regulations in terms of migrant workers, and also the hukou system that somehow still restrict a lot of mobility in a way that is inconsistent with the current economic development. So China is fortunate, but also unfortunate, because I think in many areas it is still now carrying the baggage with a lot of the old system that hasn't completely gotten rid of yet, and is tying itself down in a lot of area of development. And it would take times to get rid of them. And some of them should be preserved, but some of them is tying people down. One of them is this hukou system. I think the session is supposed to end at 11:30.
Okay, I've just been told that we've gone over the time for ending, and so let me thank you for being here and thank our panelists.